So good afternoon or even good morning, and in fact, for some of you, even good evening for all those people joining us from across the globe. Welcome to the first of what will be a long-running series that we, the ECH Alliance, are looking to run, focusing on a particular thematic around cancer. Today, we're welcoming not only a global audience, but also a global panel to give input and insights into what are both the barriers to and some of the best practices in prevention, cancer prevention from across the globe. Because obviously it's very easy to get a focus in on one region. First off, though, I'll do a quick introduction in terms of who we are for those people who don't know the ECH Alliance, in terms of what we do, where we do it, etc. My name's Andy Bleeden. My background's in health and social care. I've been working in health and social care for best part of 30 years. That's been a process where I've come into contact with people living with and sadly not living with cancer over a number of years. And what's been astonishing is the way that we see cancer across the globe and being reinvented all the time in terms of reinvention of ideas and solutions. So hopefully today's content should perhaps move away from that and stop people reinventing the wheel. Just for those people who don't know who we are, the ECH Alliance are a member organisation, okay? So what that means in practice is many of the people on this call are members of the ECH Alliance. We have a membership of around 1,100 organisations, which are focused all across the globe and brought together in ecosystems. Some of them are geographic, and we've got 80 of those, and some of them are thematic, like today's ecosystem. These ecosystems bring together all the stakeholders of health. But as a member organisation, we're charged with doing 4 things, okay? We connect to our members, we convene events such as these and ecosystems. We also amplify what our members do, whether that's our members in Turkey with Berna, who's on the call today, or indeed with Marius and his fantastic work he does from Romania. And then lastly, we accelerate innovation. So we want to pick up the best innovation from some of our members and also our ecosystems, which is why we brought in members from the US, from our US ecosystem in Massachusetts to bring, and some Florida, sorry, to bring in the best practice from the US as well, and see where we can accelerate that across the globe. So you hear from them later on. What that means in practice, though, is our ecosystems are permanent, they're multi-stakeholder, and they bring all those stakeholders you can see in front of you together in permanent gatherings, looking to both match need and solution, but as many of you have been involved with healthcare know, bring together and tackle silos, those break down those silos that prevent best practice being adopted. In healthcare, we have a particular problem around silos and people acting in silos, whether they're policymakers or funders or healthcare professionals with big egos or researchers with even bigger egos. The trouble is those silos prevent adoption of innovation. So we use our ecosystems to use those, to break down some of those silos, actually do something and transform healthcare delivery, as well as create economic growth as well. And we've set up a international network of these ecosystems across the globe, some of which you can see on the globe on the map here. Turkey obviously is here. We've got ecosystems in the US, but this is out of date every day because we've had new ecosystems join us from Los Angeles, from Singapore, from hopefully soon Switzerland. But this, for many of our members, is a fantastic way to network, collaborate, and also I see this as a giant implementation network for best practice implementation across the globe. And that's a little bit what we're looking to do today, to bring in best practice from Latin America, US, Africa, Europe, Turkey, in ways that we couldn't usually do if this was a face-to-face call. What we've also looked at is then to build up a series of what we call thematic ecosystems, which operate in the same policy of matching needed solution, breaking down silos, but on a number of different topics, which brings us to today's topic, which is around cancer. And the idea behind this is partly linked to a project we're involved with colleagues on the call today for Pecan Health, and you'll hear more about that later. But also to bring in best practice from our members, our ecosystems, and our project partners around the globe. So without further ado, I'd like to be able to then hopefully look to pass on to my colleague Marius and then end my slides. But before I do, one of the things we're going to also talk about later on today is where we can showcase some of this best practice. And this might be at one of our events that we're doing globally. So you may want to join us in some of our events, and you can see some of the information here in front of you. So that's enough from me. I'm going to hand over to my colleague Marius. Marius.
Thank you so much, Andy, for the introduction. Very pleased to be here today with you all. I'm Mario Janta. I'm the founder of the Center for Innovation in Medicine and the coordinator of the 4PCAN project already mentioned by Andy. And if I can share my slides. Yes. Good. The topic of my presentation is why cancer primary prevention really matters. So I think there is no other way actually than to focus on cancer primary prevention, cancer prevention in general, in order to change this very complex system that is cancer from a biological perspective, from a health system perspective, from a societal perspective. It is a really, really complex system. And when it comes to prevention and primary prevention, it's even more complex because of many risk factors involved in this. And the key risk factors are part of the European Code Against Cancer and the recommendation that the code includes, but as well the complexity around the implementation of this recommendation in real lives and real practice. The Cancer Mission is one of the key initiatives at the European level, aiming actually to change the way we know that cancer is, and the scope, the mission on cancer is to, by 2030, more than 3 million lives to be saved, or people living longer and better. And as you can see in green, one of the pillars of the Cancer Mission is to prevent what is preventable. But for that is not important just to focus on the prevention, but as well to consider at least the understanding, but as well the equitable access to primary prevention. And we'll discuss about this. I had a chance actually to contribute to the development of the Cancer Mission in the last years and to interact with people from the Cancer Mission Board. And it's always a pleasure to quote Professor Christine Chaumian, who is the vice chair of the Cancer Mission Board, who in February 22, more than 2 years ago, said that now is time for the next level of engagement in the cancer mission, the engagement with the citizen. And Christine mentioned that we can no longer fight cancer as we policy and scientists think it's important, but we should look to the patients and citizens and to work with them in order to change the cancer landscape. And this is how actually things aligned and the 4PCAN project emerged. And we are actually celebrating tomorrow 1 year anniversary of the 4PCAN. Project 4PCAN stands for Personalized Cancer Primary Prevention Research through Citizen Participation and Digital Enabled Social Innovation. We are 17 partners from 11 countries with many countries from Eastern Europe. That's why I mentioned the equity dimension and inequalities in relation with cancer, in our case, cancer primary prevention. The way in the 4PCAN project we are looking to the cancer primary prevention is through the lens of determinants of health, and in particular the social determinants of health and individual behavior as a determinant of health, really relevant because this part, 60% individual plus social determinants of health, are usually neglected, are not part of the current ways of implementing cancer primary prevention campaigns or initiatives in different settings. It is a really complex project for PCAN, and in the project we are looking to the European Code Against Cancer recommendation and to the risk factors for cancer from socio-economic perspective, from policy perspective, as well from informational space perspective, including the fake news and disinformation and misinformation around risk factors and measures to decrease the impact of the risk factors. But as well, we'll go at micro, meso, and macro level, and we are implementing a personalized communication model, and I'll refer to this a bit later. With our project, we are covering at least 7 out of the 13 recommendations of the cancer mission, and I will raise your attention to the recommendation number 12, accelerate innovation. And for PCAN, it's a really innovative project on cancer primary prevention. Accelerate innovation, create oncology-focused living lab. And in our project, we are actually started to create. We initiated 2 cancer primary prevention focused living labs, one in Romania and one in Bulgaria. And I refer to the Romanian living lab that was established in the Argeș County in the center of Romania. And basically, we started our activities in a rural village in the north of this county. The main objective of the Romanian Living Lab is to create a real-world model for the cancer primary prevention recommendation to be included to inform the European Code Against Cancer 5th edition. A key partner in our project, and I'm very happy to be here today with Carolina and Ariana from IARC. IARC is one of the key partners in the project and is currently developing the European Code Against Cancer 5th edition. So 4PCAN project has the potential to actually real-time inform the development of the code and hopefully the to improve the implementation of the code in real life. So we started actually to our work, and one of the first findings when we tried to understand the environment, the stakeholders on the cancer primary prevention, we used the NetMan methodology, and we actually identified around 130 stakeholders, traditional, non-traditional, at European, national, regional, and local level. So this is really impressive. So many stakeholders, so it's really important to be able to prioritize, to stratify, and to identify who are actually the most influential. And the local and regional authorities are actually underestimated in the cancer primary prevention, despite the fact that these authorities are so close to the citizen, and then they can actually influence the implementation of the European Code Against Cancer, of the recommendation and cancer primary prevention activities. So we'll work on this in the months to come to have more granularity and understanding all these interaction. But we, in parallel with working with the stakeholders, we started to work with the citizens. And we use for the first time the social and personal network analysis to understand the social tissue in this village in the north of the Living Lab. But also we organized the first citizen engagement activities around the European Code Against Cancer. And I hope we'll have the chance in the discussion to enter into more details about the activities performed so far and early insights coming from this. So this is the current state of the play of the Living Lab. Again, I can explain and enter into more details, but what the key message here is that we already are in the 3rd iteration of the Living Lab after 1 year. So we can expect a much complicated picture at the end of the project, but hopefully with more actionable insights coming from this. But why is so relevant? It's so relevant because a lot of people in the EU, but as well worldwide, are actually living in rural areas. Mm-hmm. And the risk of poverty and social exclusion is very high for the people living in rural area compared with the urban areas, as well as this risk of digital divide, not mentioning the access to health and care. So basically, a lot of people in the EU and worldwide are living in rural areas and are facing more or less the same challenges as the people from the Romanian Living Lab we established. So being able to understand this environment, the stakeholders, the interaction, the way people react to this intervention hopefully will inform future activities, future campaigns on cancer primary prevention, not just in Romania, on Eastern Europe, but as well in EU and worldwide. This is, I think, my last slide, and it's, I think, a very nice example on how a community can react to a research and innovation project. In this village, there is a football team. They are playing in the fourth Romanian league, so they are not playing in the Champions League. But when it comes to cancer primary prevention, they are in the Champions League. The coach of the team called me and asked me if I agree that 4PCAN logo to be on their t-shirts and to play wearing our logo. And I say, that's great. That's great. And what I can say, apart from wearing the logo on the t-shirts, already media become interested. They have been in national broadcasting radio station discussing about this. So a lot of noise created, and was something that came from their side. So we just stimulated the community, and then we have been able to capture this early sign of what we hope to be a future success. I will end by thanking to my team, Center for Innovation team, a lot of people involved in this project, and thank you so much.
Wow. I'm always unsurprised that Marius finishes on time, dead on time. He has the most
Really?
slides, the most information, but always, as you think there, as you said, I think you can see there, fantastic levels of information. For those people who want to know, we will share all the slides from today. That's fine, as long as people are okay with that, we've presented them. But the idea is this is a great invitation for you to take part and get involved with this project and learn about some of the lessons, best practices, and also maybe some of the failures that you get within projects. So that's an important thing we see with work. And Marius, thanks for that. I think prize already goes to you for the busiest slide I've seen so far today. One of your first slides, fantastic level of detail. I think I could rate, we'll come back to that and show that perhaps later on in the video in a bit of a deep dive. Okay, that paints the picture of the program. What I would like to do now is, as we set out with our purpose of today, was to look around, looking at what's the need and what does good practice look like. So what we've now got are 4 speakers looking at some of the barriers from not only Latin America, but from Europe, from Nigeria and Africa, and also in Turkey. What are the barriers and how people overcome them in terms of best practice in cancer prevention? So first up, I'm going to introduce our colleague Carolina, who's going to tell us about some of those barriers in and around Latin America. Carolina, over to you. The floor is yours.
Thank you, Andy. If I can share my screen, Marius, I think you're still sharing yours. Thank you so much, Andy. I indeed am going to talk about a project that we conducted in Latin America. I don't know if I would be sticking too much to barriers and best practices, but at least I'm going to share our learnings.
Wonderful.
Just a second. It's a bit of preparation. Now, can you see my slides?
Perfect.
Thank you. So I'm Carolina Spina. I'm a cancer researcher at IARC. A few words about IARC is the acronym of the International Agency for Research on Cancer. For those who are not familiar with it, is the specialized cancer agency of the World Health Organization, and we are based in Lyon, France. IARC's mission is to reduce the global burden of cancer by providing the scientific evidence for cancer prevention, and we do it through promotion of international collaborations in cancer research across the world, and particularly in low and medium income countries. IARC also produces landmark publications on cancer prevention, such as the monographs on identification of carcinogenic hazards to humans, or WHO classification of tumors, or the Global Cancer Observatory that provides the global cancer statistics, as you can see on the slide. These are the latest global statistics. In 2022, there were more than 19 million of new cancer cases around the worldwide, occurred worldwide, and around 10 million of deaths due to cancer. Since I'm going to speak about Latin America and the Caribbean, on the bottom you can see the figures of this region of the world, and here the projections for 2045 that show an increase of around 70% of new cancer cases and 80% of deaths due to cancer. And this is the region of the world that would suffer a largest increase by 2045. What is more dramatic is that these projections are only calculated with demographic changes, so the risk factor effect is not even computed in this estimate, so it may be even larger. I want to present now the World Code Against Cancer Framework, which is an initiative from IARC that aims at transforming the knowledge from etiological cancer research, means the causes of cancer, and effective preventive interventions into actionable information, or in other words, to provide evidence-based recommendations on cancer prevention to the general public. The aim is to produce a region-specific educational tool on cancer prevention, what we call the Codes Against Cancer, that comprises the cancer prevention priorities for a region, and a region such as the European Union, for example, or a region such as Latin America and the Caribbean, to provide preventive interventions that are feasible and implementable. The first code produced that has served as a model is the European Code Against Cancer that Marius already mentioned, which is an initiative from the European Commission with more than 30 years of existence. And at IARC, we are currently coordinating the development or the update of the 5th edition of the European Code. And since IARC has a global mandate, we have started producing codes for the other regions of the world, starting with Latin America and the Caribbean. And there's also interest for a code for Asia, Africa, and Middle East. These regional codes also provide recommendations for policymakers, but they do not replace national guidelines, but rather should enable governments to commit to reach the recommendations as targets, to inform policy formulation and programs, while empowering the public to follow the recommendations about the risk factors and effective interventions that will allow them to change unhealthy behaviors and to ask for preventive policies and services. I would like to show you specifically what these codes against cancer are. And since my talk, again, focuses on Latin America and the Caribbean, here on the slide, you can see the first edition of the Latin American Code Against Cancer, Latin America and the Caribbean Code Against Cancer, launched in October 2023. And this is the latest code against cancer produced. It consists of 17 recommendations on primary and secondary prevention of cancer for the general public of Latin America and the Caribbean, along with 17 recommendations also for policymakers. Here on the slide, you can see only the recommendations for the public. These recommendations are divided in 4 groups, 7 recommendations, the first sort of orange, on lifestyle risk factors, 4 recommendations on environmental and occupational risk factors, 2 big recommendations on infections and related interventions, and 4 other medical interventions such as drugs and cancer screening. I do not know if we have audience from Latin America and the Caribbean today, but if just in case, I leave here the website. You can scan the QR code on the top right where you will find these recommendations for the public. This website contains information in Spanish, English, and Portuguese. And as an example of the recommendations, very important for Latin America and the Caribbean, the code includes guidelines for the general public on indoor and outdoor air pollution, as you can see on the left in blue, here in blue, with the corresponding recommendation for governments underneath in black here, to establish the air quality standards and other policies that are needed. On the right, you can see more information that you will find in the website, like all the peer review publications related to the project, infographics, names of all participants, etc. So I really invite you to go and visit the website. On one of these publications that I just mentioned, referred to the communication study that was performed during the development of this Latin American and the Caribbean Code. In the project to develop the recommendations and other materials, we had a working group on communication who carried out a mixed method study in the 5 countries that you can see on the map. They conducted a quantitative questionnaire and 2 waves of semi-structured interviews in the general public of Brazil, Colombia, Peru, Chile, and Puerto Rico. as they wanted to assess the understanding and persuasiveness of the preliminary messages of this code against cancer for Latin America and the Caribbean, why it was developed by the other technical working groups of the project. This slide shows the results of the draft recommendations. So the order showed here on the right, and the grouping of the messages is not the final version of how the code looks like now. In this study, they saw that the messages were generally comprehensible, but some recommendations were a bit confusing, such as the one on promoting breastfeeding for breast cancer prevention, or the one on screening and testing to detect and cure the infection caused by the bacteria Helicobacter pylori, which causes stomach cancer. Difference among countries were notable, where Brazil, for example, reported the lowest comprehension and persuasiveness, while Chile reported the highest. As regards the interviews, participants prefer recommendations presented as suggestions rather than impositions, positive statements instead of negative ones, shorter and clearer messages, and they reported not to believe that sun exposure and alcohol were cancer risk factors, for example. And the recommendations on viruses, again, that cause cancer produce some difficulties in understandings. But in general, the study suggested that messages on cancer prevention are well understood by the public of Latin America and the Caribbean, although people, again, prefer more familiar language, and messages that would promote behavioral change in a less normative way, which, however, contradicts a bit the evidence that shows that prescriptive norms are more associated with behavioral change. Now, looking at how to implement these cancer prevention recommendations in Latin America and the Caribbean, I would like to show the results of a couple of studies that we did before developing the code. It was formative research. This one was designed to explore mHealth as a potential dissemination channel for the recommendations in the region. So we did a population-based study in Colombia to look at the coverage and acceptability of mobile phone messages for cancer prevention. Results showed a high acceptability of over 80% among participants as regards the usefulness, understandability, timing, and frequency of the messages. One message per week, in this case, voice message, was declared as receive and listen. However, other frequencies resulted in high reception call, but low willingness actually to read and listen the messages. In general, there was low participation rates in the study, unfortunately, and a gap between the declared acceptability and the practice in reality, and low willingness to read or listen messages. The results indicated that mHealth should be part of a multi-component intervention and not considered as the only intervention alone, at least in this country. Therefore, for our code for Latin America and the Caribbean to have an impact on the public, it would need to have a wide reach and proper dissemination channels to overcome illiteracy related to health and cancer prevention. Finally, also related to implementation research, our collaborators from Argentina and Colombia performed a qualitative study with health managers and decision makers of these two countries to investigate the perceptions of the usefulness of developing and implementing a code against cancer for the region and to be implemented in their countries, to assess whether this code would actually stimulate changes in public health policies. We followed the Consolidated Framework for Implementation Research, or CIFIR, to look at outcomes such as acceptability, appropriateness, feasibility, and relevance of implementing such a code against cancer and its potential impact on local policies. The results of the study in both countries showed high acceptability, relevance, and viability for a Latin American code to be used as a tool to enhance current cancer prevention and control policies in these countries, although some adaptations to the local context were recommended. So finally, the take-home message is that the Latin American and the Caribbean Code Against Cancer is a useful educational tool for cancer prevention and to formulate policies. Cancer prevention literacy in the region is not homogeneous among countries. Dissemination channels such as mHealth should be integrated. Oh, I'm sorry. I just realized this was in the middle. Dissemination channels such as mHealth should be integrated in a multi-component intervention, and monitoring and evaluation of the impact of this code in cancer prevention literacy in the long run is needed. Thank you so much. I apologize if I was a bit too fast. I was scared by Andy keeping the time. So
Excellent,
I hope,
excellent. Very good
I hope it
presentation.
was. Thank you so
And
much.
some fantastic resources. Again, we'll share these, and please feel free if you've got any links for us to share for the rest of our audience. Please share them with colleagues Adriana and Fede in the chat, and we'll share those wider for your organisation. Let's connect some dots here, because we're a connector at the end of the day. We've talked about being based in France and in Lyon. We have many organisations that are members of ECH Alliance, including the Cancer Bowl in Lyon, Clara Network,
Oh, yes.
in Cyprus also, in Estonia, Northern Ireland, and in the US with our just the American Institute for Cancer Research. So there's so many different dots to connect with the organisation and the community we have. So let's do that now. I want to go now to introduce our next speaker, who is Ariadne, also from a similar organisation. Ariadne, give us a picture from Europe, if you could, about the barriers in disadvantaged populations, etc.
Thank you, Andy, for the wonderful introduction. So my name is Ariadne Feliu. I'm a postdoctoral scientist at the International Agency for Research on Cancer, actually working with Carolina on several implementation research projects, like the one I would like to present to you today, some preliminary results in the framework of the European Code Against Cancer. So just to give a little bit of background, the Europe's Beating Cancer Plan that was launched in 2021 announced the update of the European Code Against Cancer. I will call it ECAC from now on, as a health education tool to improve citizens' health literacy on cancer prevention. And it set the goal to make at least 80% of the population aware of its recommendations by 2025. So unfortunately, there has not been a systematic monitoring of the impact of the European Code over the last years, since its beginning in the 80s. But results from a study conducted by IARC together with the Association of European Cancer Leagues showed us that despite the level of awareness of the population being low, between 2 and 21%, 60% of the citizens were willing to make behavioral changes to prevent cancer after reading the recommendations of the code. But we believe that further research was needed to understand the social determinants that conditioned the adoption of cancer prevention actions to ensure that citizens can turn their willingness into a reality. That's why the Commission, to develop the 5th edition of the ECAC to IARC, offered us the opportunity to conduct some formative research to help decide on and describe the needs of the target audience, understand the factors which influence their changes of behavior, and determine the best ways to reach them. In other words, to inform these new recommendations of the code. So to do so, we used the COMBI model of behavior that has been widely used to identify what needs to change for a behavior change intervention to be effective. This model identifies 3 factors that need to be present for any behavior to occur. These are capability, opportunity, and motivation. It states that individuals to perform a particular behavior, in this case, adopt a cancer prevention recommendation, they must feel that they are both psychologically and physically able to do so, have the social and physical opportunity for the behavior to happen, and want or need to carry out the behavior more than other competing behavior. So this model recognizes that behavior is influenced by many factors, and that behavior changes are induced by modifying at least one of these components. Improving the implementation of evidence-based practice and public health depends on behavior change. That's why our colleagues from the UK developed the Behavior Change Wheel. That is a framework aimed at helping intervention designers select between the different types of interventions and policies that can be used to change behaviors. As you can see, the COMBI model is at the center of the framework, forming the hub of the behavioral change wheel, around which are positioned the 9 intervention functions aim at addressing deficits in one or more of these conditions, and 7 categories of policies that could enable those interventions to occur. So this is the framework in which we embedded our research. Our objective was to explore the perceived barriers and facilitators towards the adoption of cancer prevention actions recommended in this case by the 4th edition of the European Code Against Cancer among citizens of the EU. To do so, we designed a qualitative study using an exploratory research methodology to obtain information from adults with no previous diagnosis of cancer through in-depth semi-structured interviews. Participants were selected using a quota sampling strategy that allowed us to predefine the number of participants we needed to include according to a particular set of characteristics relevant to our research question to achieve saturation of speech. These characteristics, according to the literature on awareness of cancer prevention actions, were sex, age, and educational level. We are currently conducting the thematic content analysis of the data to identify common barriers and facilitators, and at a later stage, we plan to critically analyze participants' discourse to understand the contextual factors influencing their perceptions. So this is a map of the countries we have included. We have 9 European Union member states that participated in the study, including Romania and Bulgaria, that are part of the 4PCAN study that Marius just presented. We conducted 18 interviews, 1 per each sociodemographic profile in most of the countries, giving us a total of 136 interviews to analyze. In Romania and Bulgaria, the fieldwork is still ongoing, and that's why they are in yellow, and we expect to receive some more interviews to include in our final analysis before the summer. So the complexity and the magnitude of this study, due to the extensive sample size and the different native languages in which the interviews were conducted, posed some challenges, some of which were overcome using some innovative approaches based on artificial intelligence technology. For example, using an AI-assisted translation tool to translate the transcribed interviews to English, or conducting the first round of text screening and data codification using an AI-assisted tool. So some of the preliminary results. So I will start with capability. Capability refers to whether we have the knowledge, skills, and abilities required to engage in a particular behavior. Here, I will focus on psychological capability. Related to personal health literacy, we have lack of information, which makes citizens believe they are not exposed, lack of knowledge of a risk factor, for example, radon, but also lack of knowledge between the association between some of these risk factors like alcohol or weight and cancer. Also, they found a lack of guidance on how to put the recommendations into practice, and the younger groups felt they had a low risk perception. Also, receiving contradictory information, participants found it confusing, misleading, and discouraging. They also found that sometimes they have an information overload that hinders effective decision-making related to health, and even some misinformation. If we focus on psychological characteristics, which refers to the enduring traits, attributes, or qualities of an individual mental function and cognition, we have lack of control. They felt that for some of the environmental risk factors, they had nothing to do about the exposure, for example, for radon, secondhand smoke, or occupational hazard. They could not control if they were exposed or not. Lack of concern. Some of them felt like, okay, we don't worry about these things. And also a lack of trust in the benefits of cancer prevention, and also vaccine hesitancy in some countries. And finally, related to psychological resources, I would like to highlight that participants stressed the importance of mental health support to be able to adopt these recommendations. As for the opportunity, that refers to the external factors which make the execution of a particular behavior possible. We have 2 groups here: social opportunity, which we have cultural influence, that refers to the broader impact that culture has on individuals' beliefs, attitudes, values, and behaviors. Here we had cultural norms or standards of behavior that were related to traditions or celebrations that involved smoking, alcohol, or unhealthy foods. So it was difficult for them to avoid these risk factors. And in some countries also, cancer was still seen as a taboo. Peer influence was very important, highlighting the effect of peer pressure on citizens' behaviors. And finally, social influence related to the importance of cancer prevention as being part of social awareness, common knowledge, and how some behaviors are commonly accepted in our societies, making it more difficult to adopt the recommendations, for example, alcohol consumption in social gatherings. As for physical opportunity, our participants highlighted limitations on the access, resources, quality, and availability of interventions in the public healthcare system. Also, they found some economic factors, like, for example, the affordability of healthy products and how financial resources could influence their adoption, because healthy products, for example, are normally more expensive than unhealthy ones. And finally, they also stressed other factors such as time constraints as a difficulty to be able to adopt these behaviors. Finally, as for motivations, they stress like recent cancer diagnosis in their family was a huge vector for motivation, well-being of their loved ones, family and friend support, having overall health, not only cancer, prevention of the disease, and also having a better quality of life. So these are the results we have so far. And we believe that the understanding of how the recommendations of the European Code Against Cancer are perceived by EU citizens and the barriers and facilitators they encounter to take action is key to promote the adoption of these recommendations, to improve supportive societal and contextual structures to overcome these barriers, and to advocate for the implementation of policies that enable the adoption of the recommendations by EU citizens. That's why these results are being used to inform all the working groups that are currently developing this 5th edition of the code, especially the group on communication and health literacy, to improve communication and the uptake of the new recommendations. Before ending my presentation, I would like to thank all the people involved in this project. And if you have any question, happy to answer them at the end. Thank you.
Magic. Thank you for that, Ariadna. Very, very complete and very concise as well. So thank you for your input. Let's also think about some of the other players in the field here. We also have members here that are also connected in this field, such as the European Pain Association. We're happy to make those connections too. They're very much linked up with some of their members, such as the European Association for Cancer Research too. So some dots, and I see the dots behind you, some dots to connect within our own community. One of the important things about using this methodology of ecosystems is the fact that we can convene input from across the globe. We've already seen input from around Latin America and similarities between issues there and issues in Europe. I'm interested in finding out how other continents approach this. So I'm really, really honoured that we've got the presence from not just some of our members, but also from Nigeria, from Abuja Hospital, with Hannatu Ayuba. Hannatu, the floor is yours. Please tell us, what do you do there and what can we learn from what happens in Nigeria?
Good afternoon, warm greetings from Nigeria, Africa. I welcome you all to the occasion of the launch of Cancer Thematic Innovation Ecosystem. I'm Dr. Hannatu Ayuba Usman, a senior resident in the Radiotherapy and Oncology Department of National Hospital Abuja. All protocols duly observed. I've enjoyed the previous presentations. The Global Strategy on Prevention and Control of Non-Communicable Diseases recognizes the importance of these 4 modifiable risk factors. Very important: tobacco use, smoking, unhealthy poor diets, excessive alcohol consumption, and lack of exercise. Research has shown that if all these 4 modifiable risk factors are eliminated, at least half of cancers can be prevented. The Global Non-Communicable Disease Action Plan 2013-2020 also focuses to reduce these risk factors. Looking at smoking, the Global Adult Tobacco Survey, GATS 2012, revealed that 5.6% of Nigerian adults 15 years and above Currently, we're smoking tobacco as of then, and 17.3% of adults were exposed to secondhand smoke, with 29% of the secondhand smoke exposures occurring at restaurants, in restaurants. So imagine now 12 years after, and imagine the burden, the prevalence, and that is why we are looking at these barriers today. The barriers include nicotine dependency, peer pressure, poverty, and difficult life situations, lack of motivation, rise in shisha and hookah smoking joints in our country, rise in teenage smoking, poor housing, and secondhand smoking in certain public places. And Nigeria has overcome and is overcoming these barriers by carrying out a lot of public policies, which include increasing taxes on cigarette smoke, tobacco products, anti-tobacco advertisements, ban on tobacco advertising, promotion and sponsorship. On mass media, health information and warnings are always coming up. There's the ban on smoking in public spaces. And we have also intensified our health promotion activities, this by the ways of health education, behavioral intervention, community mobilization, advocacy, and social mobilization. From the family household level, we in Nigeria, we have a fairly conservative environment. So members of the nuclear family, the extended family, all admonish children, encouraging children not to engage in such smoking habits. At the community level, we have the healthcare facilities, we have the community health extension workers, the doctors. When patients are seen for certain conditions, you know, somehow we always give health education to encourage healthy living, healthy lifestyle. Then when you look at the community under behavioral intervention, we have the impact of, there's this multi-sectoral, multi-stakeholder collaboration with government agencies, non-governmental organizations, civil society organizations, cancer advocates, all involved. We have the Nigerian Orientation Agency, who have community mobilizers in the community. They even have now a new explainer app that gets to break down policies for the layman to understand. And we also have other agencies like the NAFDAC, Ministry of Health, and latest now we have our NICRA, National Institute of Cancer Research Training. So there has been a lot of activities going on, and we are happy that we are all part of such. Looking at unhealthy diets, Nigeria has a food and nutrition policy which seeks to provide food security and prevent and control nutrition-related non-communicable diseases at the national level, the community level, and the family levels. And this policy targets to arrest the emerging increase in obesity prevalence in adolescents and young adults by 2025. So barriers mitigating against this, eliminating this risk factor include increasing rise in cost of living in Nigeria, available diets are not balanced in nutrition. Then there's this epidemiological transition from that bulky, wholesome, natural, fresh foods in Nigeria to now the over-processed, high-caloric, poor, high saturated fat foods with explosion of fast food outlets, and vegetables and fruits becoming more expensive, especially in the urban areas, food shortage and scarcity due to the insecurity, and then food additives. Food vendors add a lot of artificial colorants, sweeteners, artificial ripening agents, adulterants, aflatoxins as a result of poor food storage condition. This is a big challenge as synergizes with hepatitis B to increase the prevalence of hepatocellular carcinoma in the region. And Nigeria has in many ways overcome and is overcoming these barriers by intense health promotion activities by way of health education at the different levels, behavioral intervention, family at the community and society involving healthcare workers, there's peer effect. And in the society, we have advertisements, we have outreach programs, awareness campaigns, all carried out by different stakeholders, multi-sectoral collaboration between public health leaders, government agencies. These have gone a long way in improving the outlook and increasing awareness about eating healthy diets. Presently, we have even advertisements on TV. We have programs like the Better You Today program. There's even a competition by Excellency First Lady of Federal Republic of Nigeria, Senator Oluremi Tinubu, called Every Home a Garden competition, and women are all running up and about to make their homestead a big orchard or garden. In National Hospital, we have a vibrant and proactive dietetics department, which gives valid multidisciplinary team input in giving individualized nutrition counseling, group nutrition education, inpatient in different outpatient clinics, monthly food demonstration classes, and hospital run rounds for staff. Looking at the excessive alcohol consumption, that's also an important modifiable risk factor. Nigeria has a high prevalence of current alcohol use among adults 15 years and above. Studies have shown up to 40 to 59% at population level use of excessive alcohol consumption. And then this has been seen more in the young. So barriers in mitigating or eliminating this important risk factor include change in lifestyle behavior, dysfunctional family settings, cultural and religious purposes. Some cultures and religions include alcohol in some of their rituals, and this could be a little bit sensitive when you're discussing excessive alcohol consumption and cessation. Excessive advertisements in electronic media and print. This is a reality in Nigeria. Then the public sale of illicit gin and packaged alcohol in sachets in public spaces is a big challenge. And indiscriminate use of alcohol by teenagers, peer pressure, academic-related stress and workload, and competition among peers. So Nigeria is overcoming these barriers by intense health promotion, multi-sectoral collaboration between stakeholders by ways of health education, behavioral intervention, community mobilization, advocacy, and social mobilization. And we even have rehabilitation clinics here in National Hospital and in some bigger hospitals. We have clinics that manage patients with drug use disorder. This includes cigarette smoking, cannabis, and alcohol, excessive alcohol use. Also, Nigeria, under public policies, has increased tax on alcohol beverages, about 73 naira per liter. Then on looking at physical inactivity, that's an important risk factor. Prevalence of Nigeria has a prevalence of at least 20% of 18 to 44-year-old population not meeting the WHO physical activity guidelines by the Global Status Report on Physical Activity 2022. And the barriers include low motivation, lack of knowledge or importance of exercise and physical activity, rising safety concerns when people go out to carry out exercise and they are harmed by robbers, lack of walkways, increasing rise in the use of cars, and now easy ways to contract a taxi. Just a click. You could use your Bolt app or Rider or Uber and get a cab. So ways in which Nigeria is overcoming these barriers include health promotion, and public policies. For health promotion, it's the health education, behavioral intervention, community mobilization. In the community in Nigeria, we encourage walking during certain days when we commemorate the World Cancer Days. There's different kinds of walks like the Medicaid walk, cancer, walk away cancer, the Project Pink Blue, the Women in Nuclear walks, and so many other NGOs, CSOs. Nigeria has a rich cancer ecosystem, and we are very happy and glad that now we have a rallying point, the National Institute of Cancer Research and Training, NICRAT, which has been mandated to see to cancer prevention, diagnosis, treatment, and control. This agency is now bringing and streamlining different NGOs, CSOs, cancer advocates to come close, streamline, standardize their preventive efforts, which were initially in silos. Now they are trying to make it streamlined, standardized, and even encouraging collaboration in carrying out all these health intervention and cancer prevention efforts. Then the next risk factor, because of time, I had to just take few. For the vaccination part, Nigeria just introduced single-dose human papillomavirus vaccine into its routine immunization program. And the first phase multi-age cohort was in September 2023, and this involved 19 states. Now we're preparing for the phase 2, which is going to be in the first quarter of 2024, May, and it's going to involve 21 states. This involves an outreach to the schools, and then outreach to communities. And there's going to be this 2025 transition to full routinization for the HPV vaccine in 9-year-olds. This is a big achievement. It's a big achievement, and we're very happy and glad that we are seeing such in our time. So barriers to attaining HPV vaccination includes lack of knowledge about the human papillomavirus, and lack of knowledge about the HPV vaccine, fear about safety and efficacy of the HPV, but the perceived risk of HPV infection. People feel like they have very low risk of being infected, and then the fear of sterility or infertility, the fear that their girls will become promiscuous, lack of time and pain, and fear of any negative experience from the vaccination. These have been very important barriers. However, Nigeria, we started mapping stakeholders and then intense health promotion activities, which are even ongoing now. And this includes, apart from health education, community mobilization, high-level advocacy has been carried out between the governors, state governors, the executive director of the National Primary Healthcare Development Agency, traditional leaders, religious leaders. There has been engagement of social media influencers, engagement of the media, journalists, sensitization of stakeholders. These stakeholders have been NGOs, civil society organizations, parent-teacher associations, women groups. Production of documentaries have been done, conduct of rallies and walks, and now there are so many different programs in different areas. For example, there's the Lafia Magavu, that's the call-in radio program that is in Niger, and is facilitated by the End Cervical Cancer Nigeria Initiative. People call in their local language, they listen to the program and they ask questions. There's the 4GW program anchored by the NIMA, the NIH-sponsored program in collaboration with University of Washington. This gets to hear each daughter and her mother. They give experience that, yes, this girl has been vaccinated and nothing bad happened to her. Then there are so many other programs in Nigeria. There's a Pathfinder-supported NCS program in Lagos and Kaduna. To be careful with my time, I will have to cut short many slides and many points. However, healthy behavior adherence refers to consistently adopting and maintaining positive health habits and behaviors to enhance overall well-being. This is, for example, eating a balanced diet. This is what we encourage in our patients, in our friends, in our family, in our communities. And looking at this schematic diagram of the health system of Nigeria, this is an important fertile area of productive collaboration and partnerships towards cancer prevention. Looking at the leadership and governance, I've talked about NICRAT. NICRAT is supervised by the Ministry of Health, but they have mandated to take leadership in cancer prevention, diagnosis, treatment, and control. It was established by the Establishment Act 2017. The DG, who is an oncologist, was appointed in February 2023, and they have churned out 3 very important documents: Health Research Agenda, National Strategic Control Plan, and Cancer Control Plan, and National Strategic Cervical Cancer Control. And cancer prevention is among their 8 priority areas. Cancer prevention is one of them. And these preventive efforts that used to occur in silos, NICRAT is now trying to organize the functions and improve the preventive efforts of many CSOs, cancer advocates. NICRAT is even looking at centralizing the Nigerian system of registration of cancer registration, and we're looking forward to, as soon as they are able to complete, we're going to have an upgrade into population-based cancer registries with adult and pediatric cases. And we know that with data, you can plan, budget, monitor, and evaluate cancer prevention control activities. NICRAT is also able to control awareness across, coordinate awareness across all the 36 states and in the FCT, and it's also institutionalizing screening programs at primary healthcare centers, where most of the population reside. And it's important because they are looking at collaborating with the NPHCDA in improving infrastructure, capacity training, healthcare workers, and collaboration with other partners. And NICRAT is also looking at piloting program of preventive oncology clinics. Lessons from Egypt and Portugal have shown that such clinics give a lot of benefits. And
one more minute. All
right, so they hope to involve one teaching hospital and one university in all of the 6 geopolitical zones to be able to start this pilot program. Also, NICRAT is also coordinating and trying to incorporate HPV vaccination incorporation into school health program. It also has strength. It is also looking at strengthening cancer screening by partnering with organizations with AI tools, seen to screening for cervical, breast, and presently working on validation studies with OncoSeq. There's a collaboration with NACA. This is able to leverage HIV-related and associated malignancies. This is important for research and planning of this subset of malignancies. The NICRAT is also involved in mapping out and strengthening healthcare workforce with different collaborations, different bodies seen to training from medical oncology, oncology nursing, radiotherapy, medical physics training programs. The health system is simple yet complex, but when strengthened and well coordinated, it will positively impact on population-wide inputs, cancer prevention activities, thereby reinforcing health behavior adherence in our populations with resultant better health outcomes. Thank you.
Wow. So let me just briefly, thank you very much for that. I've given a little bit more time here because I wanted to see a different picture from outside of Europe, outside of the US, and to see, you could replace half of what Hannatu's just said, and you could replace Nigeria with any other country. Same problems: alcohol, diet, exercise, etc. The difference is, I see there examples of where Nigeria has actually got on with it. So I think hopefully a lot of your heads are spinning with the detail here, and already hopefully we'll be reaching out. Well, obviously you can connect directly with Hannatu on LinkedIn. I'm sure she'll leave her contacts here, but I think that shows a shining light on a particular country's approach that I think is really radical and seems to have an impact. So thank you very much for that. Thank you very much. Really, really appreciate your input and detail and commitment to this. I now want to focus now out of Africa, because we're moving around the globe, because I'm sure my colleague there in Turkey, Berna Kokar, is there waiting to come in to say, you think you've seen everything in Nigeria. Wait until you find out what we're doing in Turkey. Berna, come on.
Hello.
Hello.
Nice to see you all here, and it's really great to be a part of this panel. Actually, all the presenters are really very well equipped, and they touched all the subjects that I was planning to touch. So I will be more brief.
Excellent. That's the correct answer.
I know. I read the answer sheet before coming here. Okay. 1 second. Let me share my slides.
Berna, I should say, is our lead for our Turkish ecosystem, which has been with us for just some time now, and you're going to be finding out more about her in the coming months. Come on, Berna, show us what you've got.
Yes. Okay. Actually, in this presentation, I will talk about my association.
Yes.
Our association was established in 2008 by a group of academicians, but soon it's expanded to include many different professionals, multidisciplinary professionals from different groups. Our main goal is to prevent infectious diseases through education, vaccination, and strategic collaborations. So it is not particularly cancer-causing infectious diseases, but all the infectious diseases. So I will talk about our association, and I will talk about our approach, and I will focus on what we do about cancer prevention. We mainly focus on educational, preventive, and therapeutic measures to prevent infectious diseases. And our main focus is the vulnerable populations, because we know that these populations are more fragile to the threats of infectious diseases, pandemics, epidemics, and all kinds of threats. The vulnerable populations include women, youth, Roma people here, and also, you know, we have a great flux of immigration from Syria, Afghanistan, and all disturbed regions in the world. So our vulnerable populations include those immigrants as well. We also focus on prisoners, sex workers, and we are also focusing on collaborating with local and international partners to help vulnerable populations to tackle with the burden of the infectious diseases. Here, we know that this panel is focusing on cancer, and here I want to share this slide, proportion of cancer attributes to infections by region and percentage. It is around 15% of the cancer cases are estimated to be caused by infectious diseases. So here we know that infectious diseases has a big impact in cancer cases. What we do as BOHASTER, Infectious Disease Prevention Association, we conduct community awareness campaigns, and we conduct educational workshops, including children, these vulnerable populations, these groups, and also including healthcare workers, also academia. And we are initiating research and community screening programs in the remote settings, and especially limited resource settings. Also, we are conducting lots of vaccination campaigns to remove the barriers about vaccination hesitancy. And also, of course, we have lots of activities about policy advocacy. We are mainly focusing on capacity building through global partnerships. Actually, the range of people we are addressing it starts from children until we reach the elderly. We are working with all ages, with different ethnicities, especially the vulnerable ones. Also, socioeconomically disadvantaged groups are in our focus. I won't go through barriers about cancer prevention once again, because we have listened to this from different perspectives, from different presenters. But what we do about limited awareness is the workshops and the seminars, and also some other programs that we conduct together with the schools. For example, Ministry of Education get involved in this, also with other NGOs. We know about the socio-economical disparities, and we know about how cultural norms impact the combat against infectious diseases. So this is, I mean, limited access to screening and vaccination is all about socioeconomic disparities. So this is something that we are working to eliminate. We are, for example, one of our projects we conducted in the last years was to screen sex workers about human papilloma virus, and also we had some vaccination project together with them. Also, we worked on hepatitis C screening on prisoners. We are also giving a lot of informative seminars to groups dealing with drug addicts. So when we enlighten them about the infectious diseases and how to protect ourselves from infectious diseases, somehow we protect them from cancer, because we know that 15% of the cancer cases are caused by the infectious diseases. This is how we contribute to the cancer struggle, not directly, but the diseases that we fight against indirectly stops the cancer development as well. Here I want to highlight mainly Turkey's vital role in global health initiatives. As you know, Turkey is like a bridge connecting Middle East to Europe. Whatever happens in Turkey in terms of infectious diseases will soon hit the shores of European Union countries and the US, because there is a huge flux of immigration coming from Turkey to the European Union states. Also, we have a variety of populations living in our territories. So if there is a pilot study to be conducted, or if there is a research to be conducted, Turkey can be considered a perfect platform to initiate such studies and such applications, because we have a great mosaic of cultures, great mosaic of ethnicities, and also, as I said, people in move trying to reach European Union countries. So if we are going to focus on how to eliminate infectious diseases to help fighting against cancer, Turkey would be a very fruitful ground to add in our project portfolio. And also how we can contribute to such projects. For example, I can talk about our experience, how we empower vulnerable communities. As Dr. Hanato Ayuba explained, and also all our other speakers explained, community awareness campaigns play a vital role. So we are very well experienced in those community awareness campaigns. No matter what the age range is, no matter what the ethnicity is, we know how to address these groups, and we know how to help them to collaborate with us. Also, we are very good at screening, vaccinating, and treating individuals for infectious diseases. We have good connections and good collaboration with the state authorities. It's easy for us to get all the permissions and initiate the projects, as long as these projects really are in line with the health initiatives of the state. And mainly, we are always in the same line. And we also work on promoting healthy behaviors. We conduct lots of activities like hygiene education. For example, in the primary schools, we work on hand washing workshops. I mean, no matter how small it is or how big it is, we are always active about promoting healthy behaviors and lifestyle changes in the groups. And also, we are very quick in reaching these hard to reach groups. Also, about policy advocacy and capacity building, I can say that our efforts are destined to influence public health policies and regulations. So we are using all opportunities of training and capacity building. We are very open for global health partnerships, because we believe that multidisciplinary action helps a lot. It's a fundamental necessity to start or to initiate such projects. And also for multi-sectoral collaboration, we have a lot of members from different sectors, from different disciplines, to get involved in our projects. So this is all about my presentation. And if there's any questions, if there is any way to collaborate in the combat against cancer through infectious diseases, we will be here to collaborate with you. We will be here to offer our expertise and offer our multidisciplinary group to work on and to contribute to such projects. Thank you very much.
Thank you very much for that, and thank you for catching up some time as well. I think just to bring back some attention and congratulations there, because I think what you show in Turkey, some of those ideas of how we, in many countries, we can talk quite quickly to organizations and individuals that fit the system. But in Turkey, as you said, with your very diverse population, you show, I think, very well how you work with those communities that don't fit the system, whether they're migrant communities or sex workers or people, vulnerable people. And I think that's a very honest approach, which I think many countries could learn from, because we're not successful with that, certainly in Europe, and certainly from other countries where I've been involved with this work. So I think some very, very useful work happening in Turkey, and I'm sure Bern would be very keen if you were to connect and find out more about what they do, not just around cancer prevention, but other infectious diseases as well, which is, I think, really important. So thank you very much for that.
Thank you.
I think obviously we've seen here 4 really good inputs from Latin America, from Europe, from Africa, with such detail, and also now from Turkey. But many of you are saying, okay, well, what does good look like? So we're really proud that one of the members from our, I think it's from Massachusetts ecosystem in the US, from Oatmeal Health is here. And I'm hoping that we're going to have now our next speaker, Ashish from Oatmeal Health, to tell us about their solution for cancer screening and early diagnosis.
Wonderful. Thank you so much for that introduction. My name is Ashish Basrai, and I am one of the co-founders of Oatmeal Health. And our vision is to enable AI-empowered cancer prevention for all people. We are actually based out of different regions of the United States, and I'm currently in New York City. We have other team members elsewhere in the United States, and we also see this as a global technology. But we'll focus in on kind of how we're approaching our space and how we plan to progress. So some statistics to help us embody the problem here. 50% of the US population will develop some form of cancer in our lifetime. And 1/3 of that population will unfortunately die from that cancer. On top of that, the most dramatic cancer of all in the United States is lung cancer, which kills more than colorectal, breast, and prostate cancer combined in the United States. And yet, only 5.8% of Americans are screened for lung cancer today, even if they have pre-existing conditions. So you might ask, what can we do? We've heard some social determinants of health from our other speakers. I think those are really amazing prevention strategies, as well as taking some of the actions that we learn from this data and applying it towards preventing cancer, perhaps from smoking prevention and others. We're taking a slightly different approach. So what we do at Oatmeal is we screen underserved populations for cancer at scale. We have developed unique artificial intelligence algorithms and we have combined them with a primary care construct so that we provide not just the screening, but we actually have the clinical staff on the ground at these healthcare facilities to prevent lung and breast cancer to start before it becomes a big problem. And the way that we think about this is looking at the survival rates of with our strategy and without it. And if we look at the 5-year survival of lung cancer in particular, without our intervention strategy, it's only about a 10% survival rate. That being said, if we actually catch the disease at a state where we can start to reverse it or prevent it from expanding inside the system, inside the body and the patient, there's a 90% 5-year survival rate. So you might ask, how is this done? How do we do this? And how do we enact change within the healthcare system? What we do is we've developed a variety of different algorithms that can very rapidly and comprehensively, with high accuracy, review electronic healthcare records at scale. These things can sort things such as comorbidities, vital signs, labs, prescriptions, imaging from other radiological activities, problem list, clinical notes, but it moves even beyond that. What we can do is we can even look at, say, that patient's address and say that there's a slightly higher probability that they are more predisposed to certain conditions than others. And so with that information, we can inform the primary care providers, as well as the clinical teams working with these populations and these underserved populations to support and enact change, both from the prevention side, but also in receiving the proper treatment, the smoking cessation classes that they need, and a variety of other mechanisms. And so what we do is we work with what we call federally qualified health centers. These populations tend to be people that don't have access to the same medical care as people with higher socioeconomic statuses. These are the disenfranchised people within the United States. And we believe that they need the same level of care as everybody else does in the United States and in the world. And so by working with these facilities, we've formed 6 key partnerships over the past 2 years. We're a relatively young company. And in that time, over the last 2 years, we've actually accumulated over 230,000 patients that are currently under our care today. And we hope that this system will continue to expand and grow to serve these marginalized and disenfranchised communities. We can't work up by ourselves, as the saying goes. You can go fast by yourself or big together. And so what we are trying to do is we're trying to actually partner with as many organizations that are working in the same alignment as we are. This includes those federal qualified health centers, as well as clinical interventions, therapeutic interventions, universities, as well as not-for-profits, including the American Cancer Society, the American Lung Association, and a variety of other key instrumental agents for change within the United States. And that is my presentation. I thank you so much for your time. And if you would like to connect with us, please feel free to reach out to me. My email address is in the lower right corner of the screen, and or you can find me on LinkedIn. Our website's on the left side of the screen. Thanks so much.
Thank you for that. Very, very brief, very concise, and I think a really good example of something that actually can potentially be that impact, that game changer. And I think what we've seen today, hopefully, are not only some of the barriers to cancer prevention, but also some of that best practice. And hopefully you've seen examples from Latin America, from the project itself, or PCAN, as also from Europe, as well as from Turkey, from Latin America, from the US with Ashish here, as well as Abuja with those fantastic examples, and also from the examples from Turkey with Berna. What I'm interested in now is the so what question. This is all great, okay? But how can we actually connect up some dots here? Where can we learn and bring in something that might be missing from one continent or country and learn from a country that's already got the answer? Because if we spend the next 5, 10, 20 years trying to reinvent the wheel, we've failed and millions of people will die. So we need to think about where we can learn from how we target vulnerable people, whether it's to do with zip code in the US who are being missed out because of social determinants of health, or whether they're Syrian migrants within Turkey, or as Hanatu pointed out, some of those people who aren't picking up the messages about alcohol consumption, okay, whether that's in Nigeria or Europe or across Latin America. How can we learn from that? How can we best introduce some of those connections? So if you've got any questions, please feel free to use the Q&A function. I pointed at my screen, hopefully it's probably on the different side to yours, but the Q&A button on the bottom of your screen if you've got any input. And if you've got any questions for any of the panel members, because I'm chairing this, I get the luxury of asking the first one, which is what one element from your country do you think, or from your place, would you think that was the game changer for us? Do you think it would be? So I'm going to ask that. I'm going to go back to our beginning. Marius, what do you think are some of the game changes that you've seen in your experience? And then I'm going to come to you, Hanatu, and colleagues from the WHO. Hanatu first. Marius first.
Yes, I will answer your question, but first, what I actually came from most of the presentation today is this idea of barriers. The higher the barriers, the higher the level of innovation. And this is clear, and I have seen this in Ashish's presentation on vulnerable groups in the US, on presentation in Nigeria, my talk on rural population in Europe. So yeah, and for this, I think it's important first of all to look to the barriers, to understand, but then to act. And you cannot actually act in isolation, but to put, and I really like the ecosystem from US with so many different entities coming together and trying to address this problem, from financing to AI to not-for-profit academia and so on. So I think this is the right model to go. This is the governance actually we need in order to change this. And to your question, Andy, and then I will stop. Probably the game changer will be actually on two points. One is to how to activate the citizens and the communities, and then how we'll be able to capture the messages coming from the communities and to build on based on these signals that will come from the citizen and communities. We are not as health system prepared for that. Probably we need to work on different models, but that's why we're here.
Okay, thank you for that. Ariadna, I'll come back to you from your perspective. What do you think has been one of the if you either of you of some of the game changes you see in Europe?
I would say knowledge transfer, like how we get what we scientists do, right? So now we're learning about the barriers and perceptions that our citizens have, but how can we translate that into a language that policymakers understand and they really want to, prioritize in their agendas in the upcoming years? So right now the EU is doing a lot of emphasis on cancer prevention, so that's really good. So I think we need to use this spotlight that our topic has and use all the knowledge we've learned today and the one that is out there and put it in a way that our policymakers with their data, their numbers, and their, the things they really understand that it's votes at the end. How can we engage them in our cause at the same time?
Okay. Hanatu, how are we going to, one of the questions we got from one of our audience members, how are we going to get greater levels of collaboration, do you think? Because there's obviously a lot of good practice here. How are we going to get that better level of collaboration between organizations?
I believe that the game changer is and will continue to be this very good collaboration between different multi-stakeholders. And we, from the low-middle income countries, we need to really work on our research. The NICRAT has a research agenda. We have very beautiful examples. For example, the Argo group, the African Research Group for Oncology, I was so impressed with their research. They are working on a biobank on colorectal cancer. Information data has been churned, and now they have leveraged towards going for clinical trials on immunotherapy. You see, we from low-middle income countries, we have to understand that we need our local data. Presently, we have our ACON, which is the Association of Traditional and Clinical Oncology Association, which has organized seed grants for fellowship and residents. Myself, I'm a beneficiary of one of the grants for my research. When we work towards getting local data, we'll be able to understand better the disease causation in our populations, and we'll be able to work towards standard treatment. In fact, guidelines will be modified to suit our people. When people see people with cancer undergoing treatment and getting better, this will go a long way in improving the population-wide health behavior adherence that we're talking about. Because to be honest, we need our local data. we need this data to work for us. And this research is the way going. NICRAT has a research agenda and hopes to work on early career researchers, organizing grants for them for different research studies. This will churn out local data. With all this AI coming into place now, so much is going to be brought forth that will even change treatment and give better outcomes. When we see better outcomes, people will now listen to the health prevention advice and education given to them.
Excellent. I think there's a very, very good opportunity there to connect with Marius, who spoke just now, because I think, you know, what he doesn't know about access to data, certainly across Europe and beyond, isn't worth knowing in the European context. And obviously, you've got colleagues here from the WHO as well. And I think there's obviously a great. She's put her hand up. There's obviously a great opportunity from Berna. Berna, how are we going to get better collaboration?
Well, before I answer that question, I would like to add something. We were discussing about what would be the game changer.
Yes.
In my opinion, we have to be more in the field, and we have to put more emphasis on point of care applications, vaccination, testing, because the central systems are not really serving the purpose anymore. We have to be in the most remote settings. We have to be on site, and we have to have immediate results. Our association has already tried this as pilot applications in certain districts in Turkey, for example, in the suburban regions, breaking the taboos, breaking the barriers, breaking the concerns or fears. You have to be in the field, working on the psychology on one hand, and on the other hand, implementing point of care applications. So how can we collaborate? We should focus on projects enhancing point of care applications to eliminate, of course, I'm talking about our field, to eliminate infectious diseases. If we fight against, for example, human papillomavirus, only focusing on this one, we will eliminate maybe 2 or 3 million new cases next year. Because this is what the statistics say. I'm not talking about H. pylori yet. I'm not talking about hepatitis B or C yet.
No.
If we add all these infectious diseases into the picture, we will remove a big burden from both economically and also socially. In order to collaborate, we should focus more on point of care applications, digital health, accessible health for all.
Yeah, agreed. Ashish, quickly, last word from you if we can. What do you think?
I think that patient empowerment and education is really kind of the root, at least from my perspective, of how we make transformational change. The more people have knowledge, the more that they understand their choices, and the more they understand their options, the easier it becomes for them to take agency over their own health and make the decisions that support better health for themselves and then their communities. And
last word, Carolina. I'm going to come to you for the last word, please. You're very patient there.
Thank you. Well, a bit of what all my colleagues have said, and I would like to follow up on what Ashish has just said. It's very important to have evidence, not only for the policymakers, as Ariadna said, but for the general public, and especially in these times where misinformation is all around us, and we need to point individuals to the right sources, to the evidence, to the information which is based on science and will give us the right way to choose interventions or point to the ways to be able to change healthy behaviors, etc. But also I would like to link to other comments. I mean, local data are very, very important. We are at the global level here at the IARC or WHO, and sometimes, of course, for some type of science that we are doing, we look at commonalities and risk factors that are where the evidence is the same, no matter where you are in the world. But for some of the issues, especially very specific risk factor or interventions, you need local data. You need to know prevalence of exposures or how interventions are working or can work better in certain settings. And for that, we have to promote science in low and medium income countries and resources with less resources, basically.
Okay, thank you for that. Okay, Maris, you wanted me to give you a shopping list? I'll give you 5. You need access to local data. Okay, you need to make sure you can maybe help with this project to give access and an agency to that and get in more evidence. You're going to need to develop and see where we've got more on-site programs and point of care places. And we've heard about examples of that. And I think you've seen from a very passionate input from Berna, hit the big stuff. To reach out about the HPV virus, and half that problem will probably get smaller. And then you talked about Ashish telling you about it's about patient empowerment. So take control of that, and that's key to this. And obviously there with Carolina, just tackle that misinformation, because there's so much rubbish out there on Google, Dr. Google, that we need to maybe work to make sure we tackle that misinformation. That's the purposes of today's thematic innovation ecosystem on cancer. Hopefully today you've seen a global health connector approach, bringing input from around the globe. I'd like to thank all our speakers today from the project, but also from our colleagues and partners, members and ecosystems. And thank you all for taking part. We'll share all the resources from today in the presentations. And obviously, I'm sure most of my colleagues will send you more information as well. So make some difference today, and let's not reinvent the wheel on this, because there's so much happening out there we can make really quick impact. Okay, thank you very much.
Thank you.
Thank
you.
you.
Thank
Bye.
you.
Thank you.
Thank you.
Thank you.